Hallå. Då börjar vi igen. Är ni på väg ut en del? Och en del är på väg in. Ta era platser. Jag är väldigt glad över att hälsa Merete Nordentoft. Välkommen till den här föreläsningen. Vi är glada över att du är här överhuvudtaget. Merete är ju en mycket erfaren och kompetent person med kunskaper inom många områden och lång forskning, karriär och en ledande forskare i inte bara Danmark utan runt om. Du är mycket välkommen. Ordet är ditt.
Ja, tack ska du ha. Ja, tack för invitationen och tack för introduktionen. Jag har tänkt mig att prata engelska, för jag vet att det är lättare för det svenska publikum att förstå. I'm going to speak about the implementation of early intervention services in Denmark and to mention how we went from research to practice. And I think we have in Denmark the unique situation that we have had a large randomized clinical trial which actually proved that specialized service is better than standard care. I would have liked to discuss that with Tom Burns, but I don't think he's here. And we have even calculated the costs of it, but I'll come back to that. But we're going to look into what, First, I'm going to mention that there are a lot of possibilities for intervening at different phases in psychosis. It could be that we could intervene very early, at early phases, or we could intervene later on and also in more chronic illness. And a lot of these things are relevant. But what I'm going to focus on is treatment on first episode psychosis. But it's not that all the other arrows are not important. It could be important to do some of these intervention in some of the other phases as well in order to improve the development of psychosis. There are some trials in this area, and I think apart from the OPUS trial, which I'm going to concentrate to use most of my time on, there's also the LEO trial, which actually came out before the OPUS trial. LEO stands for Lambert Early Onset, and it is from South London, where they did a randomized clinical trial where they compared specialized care to standard care, and they found reduced relapse rates and reduced proportion who had a readmission in the specialized care group. And they could see that after 18 months, and the intervention lasted for 18 months. They did a follow-up study as well, and when they came to the 5-year follow-up, they couldn't see any differences any longer. I think they only assessed people by looking into the medical records in a clinical interview. So the OPUS trial was initiated later. It's a 2-side randomized clinical trial of assertive specialized psychiatric treatment, and I'm going to present results from baseline, from first year, second year, 5th year, and 10-year follow-up. It took place in Copenhagen and Aarhus. That's why I've put these 2 red dots in the map of Denmark. So it was a 2-side randomized clinical trial, and we recruited patients with first episode psychosis. First, I'll mention some of the background. It is that we knew that there was a lot of difficulties in taking care of patients with first episode psychosis, maybe also later phases of psychosis, but first episode psychosis. And once I found this case note in a fax machine, and I've called it a bottle message because I think that was what it reminded me most of. The text was like this: Kenneth shows up in the community mental health center and asks for a consultation. He asks if it's possible that a person can come to his apartment and help him with all the problems he's unable to handle. He's now moved out of the catchment area of the center and has never used the center really systematically. And he should now be affiliated with Bispebjerg Hospital. He thinks he might have a doctor at the hospital, but he doesn't know who it is. There are also social workers at the hospital, and a copy of this case note should be faxed to Bispebjerg Hospital. And I think this is a doctor seeing a difficult situation, and the patient has actually invented the case manager. You can see he asked for a person who can come to his apartment and help him with all the problems he's unable to handle. And the doctor tries to help, but she doesn't really have the tools to do it, so she put it in a fax machine and hopes that somebody will pick it up. And I think that is more or less a parallel to a bottle message. I don't know if anybody else besides me found that case note, but that's an example of some of the things we didn't want to happen. We wanted also a very friendly approach towards the patient, so we had this notion to view the patients as a long-awaited guest who we want to feel welcome and at home during a long visit, a collaborator whose insight and attitudes are decisive for the outcome, and an individual with personal preferences that should be taken into account in the treatment to the greatest extent possible. And I think these values are also found in other modern programs where you try to have a collaborative approach with the patient. And we always provide a cup of coffee to underline the welcoming approach. So what we wanted to combine in the OPUS treatment were these three elements. Later on, more elements has been added to it, but we started out with these three elements. And they were all developed for more chronic populations. Assertive community treatment were developed for those who were difficult to discharge and difficult to engage. Psychoeducational multifamily groups were also developed for more chronic populations, and so was the social skills training. So we had to modify all of that in order to make it more suitable for a first episode patient group. But I think it was actually not that difficult to modify it. Each OPUS team consists of 8 to 12 staff members, and here are the different professional groups: psychiatrists, psychiatric nurse, psychologists, social workers, occupational therapists, and labor market or educational guide. Not all the teams have a labor market or a vocational guide, it's not all of them, but in some of the teams we have. And then 8 to 12 staff members. And the caseload was 1 to 10, maybe 1 to 11, and now we're discussing with the health authorities whether it should be 1 to 12 or 1 to 13. But it is a rather low caseload. And the task is to follow the patient during in- and outpatient treatment. There's a flexible frequency of contact, approximately weekly, and then home visits are often provided. And the task is to coordinate different institutions involved in the treatment. In the beginning, we have written the GPs, the somatic departments, but then we realized that the creditors and the social services were at least as important, because many of the patients had problems with creditors and with social services. And then we have some important tools. We have our mobile phones, which we give the number to the patients so they can call us. We do not answer the mobile phone during evening and night, except in extraordinary cases if there's a very critical situation. But it's always possible to leave a voice message or a text message, and then they will receive a call back the next day. And then we have also for the home visits in Copenhagen and Jutland different means of transportation, bikes and cars. Then we are sometimes in a situation where the patient's very reluctant and not very prepared to get in contact with services. And that could be the first challenge if contact can be established. So that's the first step. And there are also some other important issues that in some cases, much more than psychotic symptoms, for instance, the patients are worried by having received unpleasant official letters stating, for instance, that if you do not turn up on Thursday, this and that place, you lose your general welfare. That's not unusual. So in some cases, it's more like solving the social problems that is felt like a need. Patient. It could be a social problem like this, and it could also be that you are about to be evicted from your apartment, either because you haven't paid the rent or because the neighbors are complaining about too much worn-out furniture placed in the corridor or other issues. Okay, and then we always involve the families, and we would like to involve them in the multifamily groups developed by William McFarlane. But if we cannot get them into those family groups, we will do a lot of other things. We'll always involve them. We'll offer them participation in a workshop where there's a lot of information about mental illness, and where also patients who have previously been part of OPUS are telling their story, so they can also hear that it's possible to get through a severe psychotic episode. But there's a lot of information in those workshops. And then there's single family sessions, and then the McFarlane model for psychoeducational multifamily groups. It's every second week for 1.5 years. And then all through the treatment in OPUS, there's an ongoing possibility for contact to the primary team member. We do not call it case managers because we think it's a strange word. We call it primary team member or contact person. So we also have some attitudes developed towards the relatives, and I think this is not a schizophrenogenic mother. It's really the opposite. It's the closest collaborating partner. It's persons who can be of invaluable help, and it's a resource that cannot be equaled. So I think it is a very, very important group to to have as allies. The multifamily groups consist of 4 to 6 patients and their relatives. It's usually their parents, but it could also be boyfriend or girlfriend or siblings, and in some cases also grandparents. But 5 to 6 patients and their relatives. They meet for 1.5 years, every second week, 1.5 hour meetings, and they work with problem solving. And it should be everyday life problems. And I've listed some of them here. It could be what to do with medication side effects, how to wake up in the morning to catch school, how to go to school, what to say in the breaks, how to be able to move away from home when you are a little bit scared to stay in your own apartment, how to maintain relationships, conversation, what is if there's a family anniversary and you still not feel completely well, how can you take part in that anniversary without feeling, without having anxiety or feeling embarrassed, what to do during parents' holiday, and how to control drug abuse. This is just a list, but it's actually, there's a round is taken where problems could be raised, and then it's decided which problem to work with. And we had a Norwegian supervisor who came twice a year and supervised us in the first year. Now it's not that necessary any longer because a lot of people have the competences. But she said a very important sentence that I think we should all remember. It's "Thank you for being so engaged." And I think that is the most important sentence when you work with families. It's because they have a true interest in, they really want the best for their children. And whatever they do, it is a result of they wanting the best for the children. If they're critical, if they are also if they're critical towards the patients, it's because they're frustrated. They want it to be better. So I think this sentence is some kind of a magic bullet that can change all kind of frustration into something more positive, because it is the truth that they are really engaged and interested and want things to be better. So that's the point of view you take when you work with this. Okay, and then to the trial. This was, I hope you got some of the flavor of what we're doing, but of course, when it comes to everyday life and practice, there's a lot more to be said. But we included patients in the age range 18 to 45. The mean age was 26. And they should have a diagnosis of F2 in ICD-10, that's schizophrenia and schizophrenia-related disorders. And then they should not have had antipsychotic medication on a daily basis in 12 weeks or longer. And that was arbitrary. It was just to do something to determine that this was first episode patients, that they should not have had treatment for 4 years or something. So we just had to decide something. And then we had a lot of assessments. I won't go through all of them, but I'll mention that we used them in order to assess symptom severity, in order to assess social functioning, client satisfaction, and quality of life, and also demographic issues. And then we had, as we live in the Scandinavian countries, we had a possibility for also following patients in the registers. And that means that for some outcome measures, we can have results for all the patients, not only for those who actually came to the follow-up interview. Of course, it's better to have people for a follow-up interview, but it's also good that we are, for instance, we can see whether they have had psychiatric admissions, and we can also see whether they have living in an institution and that could be quite important. So we randomized 547 patients into 2 groups, half in each, and the green group over there, they had 2 years of intensive treatment, specialized intensive treatment developed for this first episode population. And the blue ones were standard treatment. Actually, standard treatment was in many cases community mental health centers, but we hadn't decided exactly that it should be community mental health centers. It could also be that some people went to a private practitioner, but the majority went to a community mental health center, which was also a multidisciplinary team, but they had a far higher caseload. It was 25 to 30, and they did not have those specialized programs that I've just mentioned, the assertive treatment approach, the family involvement, and the social skills training. And now what happened then, this is not an outcome measure, it's just to demonstrate that it was actually quite different how much treatment they got in these 2 interventions. Outpatient treatment in OPUS was 77 times during this 2-year period. That's approximately once a week, or at least 3 weeks a month. It's once a week. And in standard treatment, it was approximately once a month. So we had 3 times as many outpatient contacts in OPUS. And if you look at the family groups, there were 46% who were involved in family groups in OPUS, and only 2% in standard treatment. So you could say that the treatments were different. And then what did the patient think about it? We used the client satisfaction questionnaire, which is an 8-item questionnaire, and it was a highly significant difference there was between these 2 groups. And I've just picked one of the questions, which I think is a very good one. Would you recommend this treatment to a friend? And you can see the difference is that the green people, the OPUS patients, they in 40% they stated that they would definitely recommend this treatment to a friend. So it was there was a higher level of user satisfaction. You could also say they voted with their feet, because the dropout of treatment was far higher in standard treatment than it was in OPUS treatment. It was 4% in OPUS after 1 year and 15% in standard treatment, 7% in OPUS after 2 years, and 31% in standard treatment. So the dropout was far higher in standard treatment. And then this was our primary outcome measures, the psychotic and the negative dimension. It was measured with the schedule for assessment of positive symptoms, and it's a combination of hallucination and delusions. You can score up to 5 if you have the worst level of both hallucinations and delusions. What we can see is that during the treatment, 1 year and 2 year, I think I can point with this one, 1 year and 2 year, there's a significant difference where people in OPUS treatment had fewer psychotic symptoms than people in standard treatment. There was actually also a baseline difference. It was not significant, but you can see it looks as if they started out worse. It shouldn't have been like that, but it was that by coincidence. But they improved significantly in both after 1 year and 2 year. But when it came to the 5-year and the 10-year follow-up, there was no difference any longer. So you could say that this demonstrates that there's a positive effect on psychotic symptoms, but it only lasts as long as this intensive treatment is still lasting. When I could say that like an antipsychotic drug, you won't expect it to last forever. And you could say the same about this treatment, that of course it's effective, but it's not effective 10 years after. Of course we have hoped that, but on the other hand, you could say that maybe more is needed. We see the same pattern with negative symptoms, and I think that's actually more remarkable, because negative symptoms are very difficult to influence. With the positive symptoms, you can do a lot with the discovering warning signs, discussing compliance with medication and things like that. But with negative symptoms, none of the drugs are effective. So what we see here must be an effect of the staff members being able to identify, together with the patients, area in which they could be more active, where they could have more interest. The negative symptom is all these factors that characterize, that are such as lack of motivation, lack of engagement, poor energy, and things like that. So to be able to influence that is actually very important. But we can see the same pattern here, that it works after 1 year and after 2 years, but this positive effect disappears after 5 and 10 years. And we're very sorry about that. But I think it cannot be an argument for this not being effective. It's effective as long as it lasts, and we will need to find out how can we ensure that this positive effect can be sustained. We see the same pattern for substance abuse. It's effective after 1 year and 2 years, so a smaller proportion of people who have been treated in OPUS had substance abuse after 1 year and after 2 years, but after 5 years, and the 10 years not on this slide, but it showed the same, that it was not different after 10 years either. Then to the use of bed days, we could see that there were fewer bed days during the first 2 years, and we could see the same tendency after the next 3 years. There's a 22% difference the first 2 years and a 17% different the next 3 years. So there's at least a tendency to bed saving also after the trial has ended. And if we look at living in some kind of supported housing in institution, a group home or a larger institution, there's fewer patients in OPUS who lived in a supported institution also 5 years after. And that's one of the register-based outcomes, which we had a possibility to follow year by year. And you can see here the standard patients are those in blue, and they have, for a very long period, a higher use of days in institution compared to the OPUS treated patients. So you could say it might be that they got some skills to be better able to live on their own. And this is a very expensive outcome. You can see it's 186 days versus 280 days. So it's quite costly to have people in such institutions, and quite a large difference. And then there's some results that were not measured, but still they emerged. There's something called the OPUS panel, which was a group of former service users and parents who formed this panel. And their aim is to tell the story about living with an invisible disorder. So they want to tell how it is to have this kind of illness and contribute to destigmatizing. There's also another unmeasured results. It's an association. They call themselves the Schizophrenia Association, and they're lobbying to improve conditions for people with schizophrenia. But they also arose from one of the multifamily group. They took the initiative to form this association. So to sum up the results of the trial, we had the reduced number of bed days, 22% during the trial, and 17% later on. There were fewer who stayed in supported housing, so we concluded that OPUS treatment was cheaper and better. I've said that for years now, and highlighted it like this to try to make the politicians aware that this could be worthwhile thinking about. But we ended up in also employing a health economist, Lene Hastrup, and she's conducted a health economic evaluation of the OPUS trial and defended her PhD thesis about that last year. And what she could find, what she could show was that after 2 years, there was no difference in costs. But there we had this effect that was better. And then after 5 years, it was cheaper, and even though we could not find these clinical effects that I've told you about, then it was clearly cheaper after 5 years. Here we have the cost of the intervention are green. Of course, when you hear about such a trial or such an intervention as the OPUS, people say, oh, it's very expensive. And of course it is as expensive as this green part of the column at the left shows. But it is counterbalanced by saving in bed days. So when we look at the top of the blue bars, they are equal in the two treatment conditions. So you get a much more intensive outpatient treatment for the same money as you do in the standard treatment. She made something really fancy. It's this, where it's something called bootstrapping, where the patient's results are imputed into this figure. And what we can see in this right corner, it's the cases where the OPUS treatment was expensive and worse. And luckily, it's very few cases. And you can see here, it's cheaper and worse. It shouldn't be like that either. And here, it's expensive and better. And here, it's cheaper and better. So luckily, most of the cases are in this lower right corner, where it's actually 75% of the patients who are in this corner, where the treatment is both cheaper and better. It is cheaper with respect to money, of course, and it's better with regard to global assessment of functioning, so social functioning. Yeah. It's written in British Journal of Psychiatry this year. You can read it there if you need more details. So we discussed, of course, whether this was a painkiller or a driving license. A painkiller is only has an immediate effect and then it's lost, or if it's a driving license where you learn some skills and you can use them later on. And there could be some arguments that there was a driving license approach. It's that you learn about warning signs, you learn about effect of a medication, you learn about symptom management, and you train social skills. So all this could be something you learn and then you're able to do it afterwards. But there could also be something that can be parallel to a painkiller. It's the very assertive approach. If there's a very assertive person going out and get you, calling you up, trying to wake you up, everything, and if that person stops doing all that, you're back to basics again. And so the assertive and very supportive approach, which if all your bills, if the contact person helps you with paying all your bills and you're not able to do it afterwards, then you're back to basics again. Okay, briefly I'll mention also how the relatives reacted to this intervention, and we only have results after 1 year. But what we could see was that when we used this measure of stress, it's called social behavior assessment schedule, we found that even though they were actually invited to a lot of meetings and also involved more in the treatment, spending more time with the patient and with tasks in relation to the patient, they were less stressed. They felt a lower level of burden, according to this instrument. We also found that they learned something. First, we found that they had a higher level of satisfaction with treatment. This is some kind of the same measure as for the client satisfaction questionnaire. We have modified it so it fits to the relatives. And they had a much higher level. It's one of the most significant results we had in the whole trial. And it was questioned like this. Did the treatment help you to a better understanding of your mentally ill relative? And what you can see is that it's especially this much better category where the relatives affiliated with OPUS patients reply more than parents affiliated with or relatives affiliated with standard patients. And I think, of course, when we think of the previous figures I showed you, where only 2% were involved in some kind of group activity, you're not surprised to see that maybe you don't learn that much if you're not in contact with services. So it's also an expression of a much higher level of contact with the relatives. And then we have made a book. We have written a book. It's in Danish. I think you will be able to read it, most of you. It can be bought from Psychiatry Foundation. And it has a lot of chapters about how to do this kind of treatment. And of course, we have written a lot of papers. And if you search for it, you can find, I think I've co-authored all of them, so you can search my name and find them. And then how did it go in real world? We started out with one team in Aarhus with 12 people and 2 teams in Copenhagen with 6 people in each. And now we have 19 teams, which is disseminated all over the country. And it means that at least you can see in the capital region and where Copenhagen is, we have half of the teams. And I think that's where the treatment has been most popular, and we've had a waiting list, and it has been horrible to have a waiting list for first episode treatment. And now we hope that when we get these 10 teams up and working, that we will get rid of the waiting list. But it also means that in the rest of the country, there's not a waiting list, but there's a lot of people who haven't been discovered and who haven't been referred to treatment, because it isn't like that we have half of the patient in Copenhagen and then the rest of the other half in the rest of Denmark. It's more like maybe 35% or something like that. Okay, Now I showed you that we lost the effect on negative and psychotic symptoms and also on substance abuse. And therefore we have decided that we will investigate whether this kind of treatment should last 2 years or 5 years. Maybe 2 years was too short time. So we are in the process with a trial where we have recruited 400 patients who've been treated in OPUS for 2 years. And I think we have had a recruitment rate of almost 90% of those who were asked and who had not moved far away and who had not died. Of those who were eligible for the trial, a very large proportion said yes. And I think that's also an indication that people actually like this kind of treatment. But they were randomized to further 3 years of treatment or to referral back to community mental health centers or ACT, teams or primary care. So we recruited these 400 patients from June 2009 to, I think it actually came into January 2012. And each should be followed up after 3 years. So we have started follow-up in 2012, and we expect to have the result at the end of 2014, or maybe we will need to go into 2015. But there's people here involved in this, in that trial. Okay, then at last I've briefly mentioned that we are also doing other things. We have a large trial which we call Inclusion. It's actually an umbrella for several trials. One of them is about individual placement and support. This is trying to help people to get into the ordinary labor market. This is a figure taken from a meta-analysis about this kind of treatment written by Gary Bond. And we're going to do that as well. We're going to replicate it in a very large trial where we will enroll 750 patients. And I've shown this figure to several of you in the workshops yesterday. It's about life expectancy. And we know that... I'll cut it very short. We know that there's years lost, 20 years lost of life expectancy, and therefore we have made a trial where we try to improve lifestyle for patients with schizophrenia. And this is called the CHANGE trial, where we will include 450 patients and randomize them into 3 different kinds of treatment, of which one of them is a lifestyle intervention. So I think there's a lot of things to do in first episode psychosis, and here I've listed a long list which I don't think I will be allowed to mention. But it's not only what we included in OPUS, there's a lot of more things that could be included. Yeah, that's it. And just to acknowledge the people I've collaborated with regard to research, and also all the staff members who played a very crucial role. And we also had a lot of funding, which was very generous and enabled us to do this. And finally, all the patients who signed up for the trial. Here they are only here with the numbers. That's it.